what our goal is for today and why we're doing this webinar. This is a briefing webinar on the midpoint assessment action plans. We have a working PAOP session on November 16th, which is also an MRT public comment day. We wanted to allow other things to be discussed and covered during the morning of November 16th during the PAOP session, and thought that perhaps the best way to review this would be through this particular webinar, which would then allow us to go into much more depth and go through some questions. So this is really to show overall progress, to show the structure of the progress reporting, and then on November 16th, what we'll provide is then an update of the same metrics, but at that point using DY3Q2 information that will provide us with a full year of information to compare and contrast. So with that, I'm going to turn it over to Joe Weber, and we'll have a Q&A afterwards.
Great, thanks, Peggy. So just in terms of what we're planning to cover this afternoon, I think the first item, so there's three main areas that we want to cover as part of the webinar. The first piece is just a review of the recommendation process associated with the midpoint assessment. And then we'll very quickly move into just a conversation of some of the changes that were made to the PPS reporting in particular for fund flow and partner engagement as part of the quarterly reporting updates. And then the next piece will be a review of PPS progress on the midpoint action plans, in particular focusing on the PAOP white paper or standard modification recommendation that came out of our sessions last February. So moving into the actual recommendation review section.
We're trying to advance the slide.
Sorry, 1 second. Technical difficulty.
Go to the right here.
Yep. There you go. Very sensitive. So just as a high-level overview, so coming out of the PAOP session last February, we had 22 of the 25 PPSs had recommendations. There were 3 that came out without any recommendations at that point. The number of recommendations, there were 3 PPSs that had 1, and there was 1 PPS that had 23 recommendations coming out. The recommendations were either organizational, relating to their overall organizational efforts, things around governance, financial stability, sustainability, their workforce, or specific to project efforts where we saw that PPSs were potentially lagging in project implementation progress, or potentially in engagement of partners for specific projects. The most common recommendation, again, was what became known as the standard modification or the white paper recommendation. That was the result of PAOP wanting to put some additional emphasis on partner engagement and fund flow activities. And so 14 of the 25 PPSs received this standard modification. We've included the language, the specific language for this recommendation here just as a reference point. But I think the key takeaways on it were that there were some specific partner categories where PAOP wanted the PPSs to focus their attention. The primary care, the PCP category, the behavioral health category, so mental health and substance abuse, as well as the community-based organization and specifically the Tier 1 CBO category. And so as part of the corrective action plans, the PPSs outlined how they were planning to increase their plans to increase the fund distributions to these categories, as well as their plans to increase And so just a refresher in terms of after the PAOP got together last February, so PPSs who had recommendations were asked to provide initial midpoint assessment action plans to the IA by March 10th. Those plans were available for PAOP and public commentary through March 20th, and then final approval of the action plans was given to the PPSs by the end of April 2017. The expectation was that all action plans had to be implemented by the end of DY3 Q2, so September 30th of 2017, the quarter that just concluded last month, and that PPSs would be providing specific updates on their progress towards these action plans as part of the DY3 Q1 report, which was submitted in July of this year, and again as part of the DY3 Q2 report, which the IA is expecting to receive from all 25 PPSs by the end of the day tomorrow. So one of the things that became a focal point during the PAOP meetings last February was the conversation around how PPSs, the tools that were available to PPSs to report on partner engagement and on funds flow, and some of the challenges that PPSs were facing in terms of being able to very clearly articulate where their dollars were going and the types of partners that they were engaging. So one of the things that we as the IA working with DOH went back and looked at was in particular the item referred to as the PIT tool within the quarterly report, and how that influenced some of the PPS reporting. And so the big change to the PPS reporting was that we introduced a new tool conveniently named the PIT replacement, which was intended to allow for increased flexibility for the PPS in reporting on their funds flow distributions and their partner engagement. So one of the big things there is, as opposed to the PPSs being tied to the partner categorization that was defined as part of the state logic that was driven by Medicaid claim and encounter data, the PIT replacement allowed the PPS to self-identify those partners in the categories in which they were engaging them, and also allowed them to identify partners across categories if they were engaging them in two different capacities. One other change is that there were PPSs that distribute dollars out beyond their first level of distributions, in particular those PPSs that operate under a hub model. And so the PIT replacement include a component for the PPSs to report what we call the second tier distributions. So moving it out beyond those first payments from the PPS, but then what those partners do with their funds in terms of moving them downstream. The last piece, or the last two pieces, are specific to some of the provider or partner categorizations. For one, the hospital category, within the PIT replacement, we actually went and further broke down the hospital category into separate inpatient and ED, into an inpatient and ED category, and a hospital ambulatory category. And the idea there is to more discreetly track funds going to the traditional hospital, inpatient and emergency units versus those dollars going out to hospital-based primary care practitioners or mental health or other hospital-based providers. We also broke out the case management and health home categories into two discrete lines. Again, that was based on some feedback that there was concern about how much money was going to case management versus health home within that single category to more discreetly identify it. We also added within the PIT replacement a new category for home care, again, in response to the fact that the home care partners were being captured within a larger bucket and there wasn't an ability to discreetly identify it. The last piece was really just, it wasn't necessarily a change, but rather a clarification in terms of expectations on the reporting by the PPSs, and that was around the CBO category. We really wanted to clarify that when we look at that community-based organization, the CBO category within the funds flow area, in particular, that it's truly those Tier 1 non-Medicaid providers that fall into that Tier 1 CBO, that partners that are providing mental health or substance abuse services or FQHCs and other case management services, that those aren't CBOs in terms of the definition related to Tier 1, but that those funds and those engagements should be reflected within the appropriate category, whether it's mental health, substance abuse clinic, or even the case management category.
Yeah, I'd like to add to that. Thanks, Joe. Again, PAOP members will recall that, one of the things that they kept hearing from the PPSs was that the kind of provider reporting that was going through the quarterly reporting was inflexible, and that and that there really weren't the right categories for reporting, and clarification was kind of forced PPSs to put partners in a variety of categories so that the various partner categories were confusing. So again, with the input and basically the decision during the midpoint assessment proceedings that we needed to go forward with a more flexible tool to allow for the more accurate reporting, a major reclassification was done, by the PPSs to reclassify a lot of these organizations. So, essentially, just to give you specifics, examples of specifics, the programming logic of was where if a PPS provided a network listing and those that did not have a Medicaid ID, those were basically defaulted to the CBO category. So you could even have providers who didn't have a MMIS ID associated with it. So you can see the kind of need for that kind of at least provider number cleanup. So just wanted to provide a little bit more of that context since it's been, since that was back in February.
Yep. So thanks, Faye. And I think one thing to note as well on the PIT replacement reporting is that when it was initially rolled out, we engaged the PPSs for feedback on it to make sure that we were providing the right type of flexibility and the right type of tool to them. And one of the pieces of feedback we received was that a handful of PPSs had made significant investments in building their reporting capability to fit within the existing PIT tool. And so we have, to date, allowed this to be an either-or reporting option for the PPSs, that they could continue using the PIT as it exists within the quarterly report, or PPSs can choose to move over into the PIT replacement tool. In terms of the first quarter where it was used, DY2, Q4, we saw 11 of the 25 PPSs use the PIT replacement tool. As part of the DY3, Q1 reports, which came in this past July, we saw that number increase to 19. So we are seeing an increased uptake on it. I think that distinction and that clarification will be important when we start to dig into some of the numbers around funds flow, and that you'll start to see some dollars showing up in categories where there were no dollars distributed at the midpoint, but you'll also still continue to see dollars distributed within some of those existing partner categories. So moving into the PPS progress on action plan, on the action plans, given that the number one recommendation was around the PAOP standard modification, and given the amount of emphasis placed on funds flow and partner engagement as part of the midpoint effort, really what we're focusing on here are those two areas, and digging into kind of a look back at where the PPSs were as of quarter 2 of year 2, which is when we initiated the midpoint assessment last year, and where they've come, where they've moved to in the 3 quarters since. And the plan here is that we'll walk through the data, and then because we're receiving the DY3 Q2 reports tomorrow, that'll have their latest update on these figures. the plan is that we would provide some of these updated statistics when we're together in November as well. So, but just in terms of providing some context around what we're about to move into. So looking first at the funds flow, and the way we've structured this on both funds flow and partner engagement is that we're going to look at the overall picture, so across all of the PPSs first, but then drill down into those PPSs that had that PAOP standard modification recommendation, just to see how everyone is doing, and then specifically how those PPSs with that recommendation have changed over the 3 quarters since midpoint. So looking on this first slide, in terms of overall funds flow distribution, when we were looking at this as part of midpoint, so DY2Q2, PPSs had distributed in total just over $414 million out to partners. Looking at that now 3 quarters later, we've actually seen that go up by over $464,000 to $464 million, sorry, to a total of $878 million distributed. So in terms of a period over period shift, it's about 112% increase. So it's more than doubled in the 3 quarters following midpoint assessment. When we take a little bit of a deeper look at that too, looking at how much money has gone out outside of the hospital partners, outside of the PPS PMO categories, at midpoint, the amount going out to those non-hospital, non-PMO categories was $113 million, and we've seen a 143% increase there, or $162 million since midpoint assessment has gone out outside of the hospital and PMO category. So relative to the overall increase, the increase to the non-hospital, non-PMO has actually been a little bit higher.
So this is really substantial. I mean, if you think about that, cumulatively, from point of inception to the midpoint, that they distributed, $414 million, and then in 3 quarters they distributed more than that. For the prior 2 years, just in the 3 quarters, that's pretty tremendous. And just wanted to emphasize also what's going on here is that, in the beginning, obviously, the PPS cycle of, building up their infrastructure and beginning to contract with partners, deciding what roles partners would play, contracting with them, the partners providing services, and then the flow of payment. So I think that was also part of it, is that, now some results are, claims are coming in and payment for those services rendered were going out as well, in addition to obviously the kind of emphasis that they heard throughout the PAOP sessions.
And then, taking a step further and looking at the distribution to those 4 partner categories that were highlighted as part of the standard modification. For the PCPs, we saw a 160% increase from $14.6 million at the midpoint to over $38 million 3 quarters later. Mental health, 183% increase from $9.7 to $27.5 million. Substance abuse, again, another significant increase, 142% from $4.3 million to $10.4. And CBO category from $11.9 million to just over $28 million. So about 134% increase in the total dollars distributed in the 3 quarters after midpoint assessment out to the CBO category. And so, that is, the big picture in terms of total distributions across all 25 PPSs and the bottom line increases. What we do have on the next slide, and we won't go into this line by line because it's a lot of content, but the next slide we just show by all of the defined partner categories, all of our increases across the board, again, and following distributions at midpoint assessment, distributions 3 quarters later as a DY3Q1, and the increases there. One of the things that we mentioned earlier, but that you'll see here, and we have footnoted within here, is that at the time of midpoint assessment, we only had a single line item for the hospital category and a single line item for case management and health home. What we're seeing here, and so that's why but with the release of the PIT replacement starting in DY2 Q4, we introduced the subcategories of the inpatient, ED, and ambulatory lines for hospital, the separation of case management and health home, and also down at the bottom, the introduction of a new home care line. And so you'll see zeros there as part of midpoint for those categories, but you will see funds being distributed out to those categories starting in DY2 Q4 through what we have here in DY3 Q1. Again, all of the same increases that we saw and referenced on the first page, you can see within the detail here, as well as some of the increases across all of the other partner categories as well. So taking this a step further and focusing just on those PPSs that receive the standard modification from PAOP as one of their recommendations. And again, we have 14 of those that received that recommendation. Looking at it the same way that we did with the overall, these 14 PPSs had distributed at the time of midpoint assessment $264.7 million. Those distributions went up by 111% to $558 million. And so that's an increase of $293 million out just from these 14 PPSs. Again, the next step, looking at the non-hospital, non-PMO distributions, at midpoint, it was $71.5 million was going out to those to the non-hospital, non-PMO line. That again saw a $97 million increase, or 136% increase over the 3 quarters to $168.6 million. And so, again, as Peggy mentioned earlier, as of midpoint assessment, that was through 6 quarters of DSRIP that we were looking at those figures. And in just 3 quarters after the midpoint assessment, after the PAOP meeting, we've really seen significant increases in the amount of dollars coming out, due in large part to the feedback PPSs were getting through the midpoint, through the PAOP meetings. So then just continuing down to the bottom of the slide, again, isolating and focusing on those 4 partner categories that were highlighted in the white paper standard modification recommendation. Again, we see consistent, significant jumps in terms of percentage and dollars that were distributed. PCPs saw an additional $18.6 million over the 3 quarters after midpoint. Mental health saw over 200% increase from $6.7 million to $20.6 million. Substance abuse partners, again, 172% increase to just over $7.2 million. And then the CBOs, 145% increase, jumping from $4.2 million to just over $10.4 million in the 3 quarters of distribution. And one of the things, too, is that we are, again, because of some of the clarifications, seeing what we believe to be a much cleaner, more accurate reporting from the PPSs in terms of these distributions. And so, I think that the numbers we're seeing, again, are improvements over where we were at midpoint.
So in this particular one, this is
So again, like we had for the overall recommendation or overall funds flow, we have the same table set up for the 14 PPSs that received the standard modification. And as we said with the first slide on the overall, you continue to see some of the same trends in terms of overall increases in funds flow distributions in those 3 quarters. So that covers our updates in terms of funds flow, and we wanted to go now is into the partner engagement component of that recommendation. And similar to how we structure on the funds flow side, we've done the same on the partner engagement to first look at the total partner engagement figures, but then to drill down into those PPSs that had the PAOP standard modification. So one of the things we do want to note in looking at the partner engagement side is we have noticed with one PPS that we've seen decreases, consistent decreases in terms of the reported number of partners that they've engaged. And so we've been digging into that further with the PPS. But for the purposes of this presentation, in order to not skew the data, in order to not overlook the great work being done by the other 21 PPSs in this case, and the other 13 PPSs that received the standard modification, we have excluded them from these figures. So here on the total side, we're looking at 24 PPSs, not 21. 24 PPSs, and then on the white paper, we'll only be looking at 13 of the 14 PPSs. So in terms of overall picture, overall engagement, across all of the PPS projects, across all of the partner categories, PPS is committed to engage over 244,000 partners in implementing their projects. Keep in mind that that $244,000 figure doesn't represent an unduplicated count. It's just a total count that PPS has made commitments on, as PPSs could commit to engaging the same partner across multiple projects within their PPS, and also that same partner could be engaged across multiple PPSs as well. So it's just a total unduplicated count that PPS is committed to engage. At the time of the midpoint assessment, total engagement was 228,000. In the period since midpoint, we've seen the number increase to 429,000, so about an 88% increase in partner engagement activity by the PPSs. The one thing to keep in mind, too, as we talk about partner engagement, is we also, around midpoint, provided some clarification to the PPSs on what partner engagement meant, and helped them to refine how they viewed the partner engagement figures that they reported. And so we've defined partner engagement as a direct relationship between the PPS and the partner. So it doesn't account for a PPS engaging a partner and then that partner engaging multiple partners, kind of a second-tier engagement. It truly is the direct PPS to partner engagement, and that engagement had to be evidenced through either a contract or other formal agreement between the two organizations. At one point, PPSs had MOUs in place with partners as part of their initial planning activities, and we clarified that those MOU agreements would not substantiate partner engagement, that MOU had to then move into a formal contract or formal agreement between the two organizations. Within that engagement, we're asking the PPSs to specifically identify the services or activities that the partner is expected to perform on behalf of the PPS, and the compensation from the PPS to the partner. And just noting there that when we talk about partner compensation, it's not always directly tied to an actual financial compensation. There are a number of other arrangements that PPSs have with their partners, either through providing centralized services such as IT or staffing support that is provided in return for the PPS partner performing activities on behalf of the PPS. So looking deeper at partner engagement overall, this breaks it down by all of the categories by which PPSs made commitments in their district project plan application. Again, we can see the bottom line, 244,000 commitments. increased to 429,000 engaged over the midpoint assessment. You'll see, in particular, looking at the mental health category, that they increased their engagement by doubling where they had been at the time we initiated the midpoint. And then you also see increases across the board for the 24 PPSs that were included in this analysis. And so one thing too, because we know it's often there, is the all other category. Keep in mind that the all other is not just a loosely defined or not defined category that PPSs can throw a bunch of partners in. There is a definition assigned to it. There are specific partners that fall into the all other category. And so when we're looking at that, that's not just a catch-all bucket, which I know it has been interpreted as that in prior conversations, but wanting to just reiterate that it is a defined set of partners that generally are providing Medicaid services that don't fall into one of these other categories that are already defined. So moving into the standard modification view on partner engagement. Again, one of the 14 that received the standard modification, we've seen some trends with their reporting of partner engagement, and that I think overshadows some of the progress being made by the other 13 PPSs. So, looking at the data for those 13 PPSs, we have 164,000 partners that the PPS committed to engage in their application. When we were together from midpoint, they had engaged just over 147,000 partners. That number has since gone up to 253,000 partners engaged, or a 71% increase in partner engagement across all categories. When we dig into those 4 categories that were highlighted as part of the standard modification, we again see increases. These increases are generally consistent with what we saw in the overall partner engagement trends, but for PCPs, a 34% increase from 23,000 at midpoint to over 31,000 as part of DY3Q1. Again, we expect to see that number continue to increase as PPSs have a lot of significant PCP-driven milestones that are due at the end of DY3. In terms of mental health, we saw an increase from just over 6,000 to over 14,000 mental health partners engaged in DY3Q1. Substance abuse, an increase of 301 partners in the 3 quarters after midpoint, and for CBOs, an increase from 469 to 639 partners engaged by these 13 PPSs. So, again, the last set of data that we have is just the deeper dive, the full breakout across all of the partner types. Again, showing 71% increase of overall partner engagement for these 13 PPSs. Again, the same increases that we saw for those 4 specific categories on the prior slide can be seen here. And again, similar to what we saw in overall, we've seen PPSs continue to increase the number of partners that they're engaging. And at this point, most look to be on track for meeting their specific partner engagements from the application, that we don't see the significant gaps that we saw at the midpoint that raised concern. And there are still gaps, but again, PPSs have started their corrective action efforts and are continuing them through DY3Q2. And so we expect to see some updated figures come through as part of those reports when we receive them tomorrow. So in terms of next steps, as I mentioned earlier, we're expecting to get the second round of midpoint action plan updates from the PPSs tomorrow when we receive their DY3 Q2 quarterly reports. Similar to all the other processes, those reports then are subject to the IA's review for 30 days, so through the end of November. And at the end of November, any questions or any items that the IA flags where they require additional feedback from the PPS or additional clarification will go back to them for a 15-day remediation period. And then the IA is expected to have final decisions on all of the content by the end of December for these PPSs. Our plan is, again, when PAOP reconvenes for a working session in advance of the MRT Public Comment Day on November 16th, is to do a refresh of some of this content based on what was preliminarily submitted by the PPSs as part of their DY3 Q2 reports. And so it will be prior to the IA finishing their full review of the data, but it'll be an initial snapshot as to further progress being made by the PPSs in regards to funds flow and partner engagement activities.
Sorry, Phil, but should that last sentence be DY3 quarter 2?
Correct. Yep. So again, it'll be content updates through DY3 Q2, not DY2 Q2 is reflected here. That was when we did our midpoint. But with that concludes our presentation. I don't know, Peggy, if you have any final comments on this, but we'll be posting a recording of this as well as the slides up to the DISRIP website.
Thank you, Joe. I think, again, just to recap overall, I think we're seeing a tremendous improvement in response to some of the midpoint assessment findings, all positive movement as far as funds flow, a tremendous movement on funds flow. And again, part of this is timing as well as then I think through the type of emphasis provided by PAOP in terms of, the overall guidance and direction, and as well as on partner engagement with those significant movements in the PCP, mental health, substance abuse area, and CBOs. So, with that, we will just pause momentarily and open it up for Q&A.